Hi, everyone, and welcome to another season of free Friday live streams in the run-up to our annual virtual conference, Radiopedia 2025. My name is Bhavna Batowi, and I am a radiologist practicing in London in the United Kingdom. My subspecialty areas of interest are breast and musculoskeletal imaging. It's my great pleasure to be one of the conveners for Radiopedia 2025, along with Lee Al-Hilali and Joe Molyneux. The three of us, together with a huge backstage team, are putting together our 6th virtual conference. And I know it's said every year, but this one really will be the best one yet. You can register for the whole conference or purchase yourself an all-access pass, which gets you the conference and a heap of other content from our library. The registration page is ready, so go and check out the full lineup and your registration options. Don't forget that anyone in one of the 125 low and middle income countries listed on our website can claim free access for the whole conference. We do that because it's our driving philosophy to be able to provide education for the whole world regardless of ability to pay. Over the next few months, we'll tell you all about what we have planned for Radiopedia 2025. But suffice to say that you'll be spoiled for choice with new lectures, workshops, case sets, and anatomy teaching, as well as panel discussions from our expert speakers. One really important message for now. We have just opened our abstract submission for the R posters. The deadline for this is the 9th of March 2025. And just like in previous years, selected R posters will be shown at the conference and will receive a DOI as well as a certificate. Please make sure you put some time aside to get those abstracts in so that you can be part of our conference. Right, let's get to the lecture. This first live stream is done by none other than your favorite thoracic radiologist, Dr. Miranda Siemienowicz. She's from Melbourne in Australia, and her talk is on diffuse nodular lung diseases. And I guarantee that no matter what level of radiology you're practicing at, you will find a pearl to take away from Miranda's lecture. Take it away, Miranda.
Hello and welcome to this discussion of diffuse nodular lung disease, by which I mean a profusion of micronodularity, typically 2 to 3 millimeters in size and widely distributed. My name is Miranda Siemienowicz. Thank you very much for joining me. Etiology in diffuse nodular lung disease is differentiated by appreciating idiosyncratic nodule distribution. Nodule patterns are determined by the transit of materials through the lung in the everyday function of this organ. This is the secondary pulmonary lobule. 1 to 2.5 centimeters in size, makes up the entire volume of the lung parenchyma, and in the center of this, the terminal branches of the pulmonary arteries and the terminal airways, which bring air in to sacs of alveoli called acini, which make up the volume of the secondary pulmonary lobule and are interwoven between the capillary bed, which drains into veins and venules in the interlobular septa, taking blood back to the left heart. Multiple materials pass through the secondary pulmonary lobule. We start with air. Comes in through the center of the lobule, fills the acini, goes back out the way it came in, and disease that relates to the terminal airways manifests as nodularity in the center of the secondary pulmonary lobule because the airways can't make it out to the exterior parts of the lobule. Blood comes in through the center, through the terminal branches of the pulmonary arteries, and diffuses through the capillary bed, fills the volume of the lobule, and then drains into those venules and veins and back to the mediastinum. Disease that relates to the capillary bed will be diffusely, uniformly distributed across the volume of the lobule. Lymph drains from the lung parenchyma along 2 distinct lymphatic beds, the bronchovascular lymphatics and the septal lymphatics, Disease that relates to the pulmonary lymphatics will present with nodularity along the bronchovascular bundles and along the septa, which are anatomically continuous with the fissures and the pleura. So when we differentiate between disease that relates to these three materials, we ask one underpinning question in interpreting the radiology, and that is the pleura involved? And the answer to this question is no, sometimes, or very yes. Let's see how that works. Disease relating to the airways will manifest in the center of that secondary pulmonary lobule. As we've seen, the airways don't make it out to the edges of the lobule, so the pleura is not involved. This is the centrilobular pattern of disease. Disease that relates to the capillary bed has a uniform distribution, and the pleura is sometimes involved because disease that maps to the capillary bed will occasionally land at the septa, land at the fissures, and land at the pleura, but the degree of nodularity associated with these structures is not out of keeping with the degree of nodularity elsewhere in the lung. Disease relating to the pulmonary lymphatics will very yes involve the pleura because one of those two lymphatic beds runs in the septa, in the fissures, in the pleura, and there will be a disproportionate involvement of the pleura. So we're going to see nodularity that predisposes to the fissures and pleura as a recognizable manifestation of the perilymphatic nodule disease distribution. In clinical practice, we see images like this. So 3 separate patients with 3 different disease etiologies showing these nodule patterns, and all with high profusion, 2 millimeter sized nodules that are widely distributed. In the centrilobular pattern, we've got black lines along the fissures. So we've got sparing of this periphyseal lung. We've got sparing of the lung periphery with black lines out at the peripheral pleura. In the uniform distribution of disease, we've got nodules along the fissures, but the number of nodules, the nodule count per unit area associated with the fissures, is in keeping with the nodule count in other areas of involved lung. In the perilymphatic disease distribution, very yes, the pleura is involved. Here's a portion of the oblique fissure in the right lung, and there's nodule, 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 nodule. This is involvement of the septal lymphatics passing into the fissures, and it is out of keeping with the degree of nodularity elsewhere in the lung. And also here, nicely seen involvement of that bronchovascular lymphatic bed with studding of these bronchovascular structures. So let's talk about the centrilobular nodule disease pattern. The most common manifestation of this that we see every day is the tree in bud pattern. And the most common cause for this, 1st, 2nd, 3rd, and 17th in your differential diagnosis is infection. This relates to airways, commonly associated with aspiration as foreign material is introduced down that bronchial tree and seats and causes infection. Let's look at 3 different patients who all have risk factors for aspiration and see how these nodule patterns interrelate. This is a patient who's ventilated, and in the superior segment of the right lower lobe, they've got extensive tree and bud nodularity. We'll just look at one little example here with cluster of 3 little 2 millimeter nodules, and they surround a little central branching opacity that is the tree in the tree and bud, and that is an opacified terminal airway. It's not a vessel, it's an airway. Let's keep looking at the rest of this case because the patient has very high extent disease and a beautiful demonstration of this tree and bud pattern with these little clustered micronodules and the little branching opacities associated. Notice also the distribution of nodularity here because we've got a wedge-shaped distribution of spared segments and subsegments here and involved segments adjacent because material is introduced down the bronchial tree and it's distributed in that wedge-shaped anatomical segmental recognizable pattern of involvement. So extensive tree and bud in an infectious bronchiolitis associated with ventilation. See that the large airways are also involved. So we've got thickening of these segmental airways and we've got extensive mucus secretions within. Large airway changes go hand in hand with small airways disease. And we're always looking for that when we're interpreting these nodule patterns. Here is a patient with a very distended esophagus. When we scroll down, we've got this laparoscopic gastric banding device, increased pressure across the band, results in chronic distension of the esophagus, retention of fluid, retention of debris, and a predisposition to recurrent aspiration. In the right upper lobe, a few clustered, hazy nodules that are this tree and bud opacity, are the little buds within it. And scrolling down, there's much greater extent of disease with much more confluent opacities. But notice that all of this disease is nodular, is hazy with a central consolidative focus and peripheral ground glass opacity. And where you see these discrete nodules, you can appreciate that they are still centrilobular in distribution. Here, this nodule is associated with the adjacent bronchovascular bundle. And here, another beautiful example of these clustered confluent nodules. There's peripheral ground glass opacity, and they're associated with these branching bronchovascular structures. So this is the buds part of tree and bud. There's not a lot of tree happening in this patient with quite extensive and bilateral, in fact, aspiration pneumonia. This patient had a squamous cell carcinoma of the floor of mouth with segmental mandibulectomy and reconstruction, and that altered oral biomechanics results in a high risk of recurrent aspiration. And that's what they have. In the superior segment of the right lower lobe, again, we've got a few scattered foci of tree and bud opacity with a few nodules associated with these branching opacities. But in this case, the dominant abnormality is of that large airways disease. So gross bronchial wall thickening, bronchial dilatation, mucus impaction, bronchiectasis, and again, just those few scattered foci of tree and bud opacity. So this is the tree without a lot of the buds. So 3 patients with a wide presentation of aspiration-associated airways-centered infection, infectious bronchiolitis, aspiration pneumonia, and large airways-associated complications with bronchiectasis. Now, a phrase that everybody loves to use is infective/inflammatory change, and it's a good term, but it's also important to be cognizant of the reason that you're using terminology. So what do we mean when we say inflammatory? What are the disease entities that is running through our minds that may be a possibility in the patients that we're examining? Let's look at a couple of different disease etiologies that are non-infectious inflammatory causes of centrilobular nodularity. So here a patient with high profusion, wide extent centrilobular ground glass nodularity. Is the pleura involved? No. Look at that beautiful black line along the peripheral pleura. Look at the way that that peripheral lung is spared. In fact, the disease is so gross in distribution that the fissure, which is here, is obscured, and we're not getting a nice fissural sparing. But just look at this right midzone here and just dwell for a moment on this beautiful black lacework that is cobbled between all of this nodular ground glass opacity, because this is the interlobular septa and those partial septations of the intralobular septa that are spared in the centrilobular distribution of micronodular disease. So this is part of that beautiful centrilobular distribution. And what else does this patient have? They have these scattered, lucent polygonal structures, which are secondary pulmonary lobules, sometimes several abutting one another, that are involved in air trapping. And if we did expiratory imaging on this patient, we would exaggerate the difference between that dense ground glass lung and the lucent air-trapped lobules. And this is, of course, the typical appearances of hypersensitivity pneumonitis. So old terminology, subacute hypersensitivity pneumonitis, and updated terminology from this paper, the Clinical Practice Guideline published in the Blue Journal in 2020 of non-fibrotic hypersensitivity pneumonitis. Why have we updated the terminology? What are we trying to align with? This is in recognition of the fact that the terminology of subacute versus chronic is arbitrary. There's this chronological cutoff of 3 months that tips you into chronic hypersensitivity pneumonitis, but it doesn't acknowledge the disease process that's occurring in the background, because we know that patients who can have very long-term exposure to these inhaled organic antigens may not necessarily go on to develop fibrosis, and fibrosis doesn't necessarily begin at 3 months. So separating out the terminology away from these arbitrary cutoffs and more closely aligning with the histopathology, which indicates either the presence or absence of fibrosis, gives us a cleaner, more accurate radiological set of terms. This is a table with a lot of words. What I want you to take away from it is that non-fibrotic hypersensitivity pneumonitis requires the satisfaction of 2 criteria. So we have ground glass parenchymal infiltrate as a parenchymal manifestation of this process, and we need to also satisfy the criteria of evidence for airways involvement. And the two features radiologically that indicate airways involvement are the centrilobular distribution of nodules and or air trapping. And in the previous case, we've seen both of those features, a beautiful appearance of typical non-fibrotic hypersensitivity pneumonitis. In this case, the distribution on the coronal and axial images is diffuse, and that is all of the hallmarks of the typical appearance. Otherwise, we see other features, which we'll have a look at in this case, of more confluent ground glass opacity, consolidation, and even cysts. Let's have a look here. The ground glass opacity is still recognizably distributed in that centrilobular pattern. Is the pleura involved? No. We've got beautiful black lung out at the periphery of the hemithorax, and we do have these nice black bands along the fissures to show that centrilobular distribution. And as we come down, we've got this more confluent geographic ground glass opacity. Here, beautiful few adjacent secondary pulmonary lobules that are loosened. That's the air trapping. So ticking a lot of boxes, and another case of non-fibrotic hypersensitivity pneumonitis. The alternative differential diagnosis that people often use in the same sentence for ground glass centrilobular nodularity is respiratory bronchiolitis, which is the working diagnosis in this case. Let's have a look at what we see. So this is an active smoker. We've got scattered centrilobular lucencies, which is low volume, mild centrilobular emphysema. We do also see mild bronchial wall thickening, so there isn't bronchitis present active in this case, typical in active smoking. And then on the background of that are innumerable faint, small centrilobular ground glass nodules. We see that by just appreciating the number of round structures on each slice and seeing that these exceed the number of normal vascular markings that you would expect in this lung. I'll just scroll up and down because those moving images show it better, the profusion of these faint centrilobular ground glass opacities. So this is respiratory bronchiolitis. Histopathologically, what we see is an accumulation of intra-alveolar pigmented macrophages. Radiologically, it's this ground glass opacity, small centrilobular nodules. And what we see in these cases is that the ground glass opacity can, in fact, evolve to become airspace destruction and emphysema. So the ground glass of respiratory bronchiolitis may, in fact, be a precursor and part of the mechanical evolution of emphysema. How do we differentiate between these two diseases? The most helpful clinical practice point is the profusion of nodularity. So let's look at that HP case on the left-hand side. You can see that extensive distribution, that high profusion of nodularity compared to the lower profusion, more interspersed intermittent nodularity, as well as the superimposed emphysema in the respiratory bronchiolitis. And that nodule count, that degree of profusion, can actually be quite helpful. And most non-fibrotic hypersensitivity pneumonitis really will have that huge volume nodularity, with respiratory bronchiolitis being a much more subtle, invisible on the 5 millimeter slices degree of change. We all grew up being taught that smoking had this paradoxical protective effect against hypersensitivity pneumonitis, but the reality is that we see plenty of HP in smokers, so the most useful practice point that I find is this profusion of nodularity. So the centrilobular pattern of nodules, we're thinking infectious change, 1st, 2nd, 3rd, and 17th in the differential diagnosis. We're thinking inflammatory causes, hypersensitivity pneumonitis, respiratory bronchiolitis. The uniform distribution of nodules is most commonly referred to as the so-called random pattern of nodularity. This is a term to which I strongly object because the use of the term random indicates that this is arbitrary, that there's no meaning behind it, it's completely inexplicable, and that's just not the case. Much better term is uniform nodule distribution, because that indicates what we're actually seeing. It's describing the pattern that we appreciate on radiology, and it's acknowledging the anatomical explanation behind the disease production, which is mapping back to the capillary bed, which is uniformly distributed through the lung. Let's have a look at a couple of cases. We've got a patient here who has miliary tuberculosis, and they've got a high profusion of 2 mm soft tissue density nodules. Is the pleura involved? Sometimes. A few scattered nodules that are out in the lung periphery that are landing, touching that pleura, and along the fissures, again, a few occasional nodules contacting the fissures and pleura. Let's just scroll further through this case, and we can see that the nodule count, again, per unit area of nodules along the fissures is in keeping with the degree of nodularity elsewhere in the lung. So this is a uniform distribution, miliary tuberculosis. Another patient, same diagnosis, miliary TB, and again, a lower profusion of nodules, but that same distribution, where we've got the occasional involvement of the pleura. Is the pleura involved? Sometimes. Here, 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 not out of keeping with the degree of nodularity elsewhere in the lung. Smaller nodules that are therefore appearing more lucent than in the previous case and of lower density, but that same uniform distribution. So 2 cases of miliary tuberculosis. And just a single image from a patient with miliary metastases to illustrate the point. Occasional involvement of the peripheral pleura, not out of keeping with the degree of nodularity elsewhere in the lung. So of course, the cancers that come to mind when we're thinking about miliary metastases are those hypervascular cancers, thyroid, melanoma, renal cell carcinoma, but not to forget breast and pancreas, which can also be not uncommonly associated with this miliary pattern of disease production. So, uniform pattern, micronodularity, miliary infection, miliary metastases. The perilymphatic nodule distribution is recognized by nodules nestling in along those bronchovascular structures in association with the bronchovascular lymphatic bed and the septal lymphatic bed in a septopleural distribution. Septopleural, it's not a common word. In fact, when I looked this up, I found that it's almost not a word, but I use it because it reminds us that the interlobular septa are anatomically continuous with the fissures and the pleura, and that is the driver behind the pleural predominant component of the perilymphatic nodule distribution. The hallmark disease for a perilymphatic distribution is that of sarcoidosis. And let's have a look. Is the pleura involved? Very yes. Nodule, 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 extensive involvement of that peripheral pleura. Let's keep coming down and just admire the degree of nodularity along the superior aspect of that right oblique fissure. Nodule, 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 all landing along. As we scroll down, we also notice the other feature of sarcoidosis, which is of course that mid and upper zone predominance and the way that the nodules fade out towards the lung bases. Let's have a look on the coronal images, and we've got extensive nodularity landing along that fissure with this disproportionate involvement of the fissures and of the peripheral pleura, classic appearance of pulmonary sarcoidosis. Another case of sarcoid, similar extent disease, similar profusion of nodularity, just to show an illustration of the bronchovascular predominant manifestation of perilymphatic nodularity. So down here in the superior segment of the left lower lobe, this absolutely stunning beating along this bronchovascular bundle as it comes back towards the hilum, and up in the right upper lobe, this beautiful association with these bronchovascular bundles and extensive beating along these bronchovascular structures, beautifully seen. So bronchovascular and fissural and pleural distribution in perilymphatic nodularity. Now, the disease that people mention in the same breath with sarcoidosis when differentiating between different etiologies of nodular lung disease is silicosis. Another example of perilymphatic disease distribution. So here is a stonemason. We're starting down at the lung bases and we've got nodules scattered out along the periphery of the lungs. So is the pleura involved? Very yes. We're already seeing that relationship with the peripheral pleura. Let's keep coming up because again, this is a mid and upper zone distribution disease where we've got relative sparing of the lung bases and the action happened much higher up. And as we come up, there's greater profusion of nodularity. There's more and more nodules landing along the periphery of the lung and landing along that fissure. Look at the distortion of the fissure associated with that nodularity. And as we keep coming all the way up, these nodules, which are peripheral and peribronchovascular, are associated with this reticulation in a perilobular distribution at the center of the lung apices. It's more so on the right, it's bilateral, and it's really in that center part of the apex of the lung. This is a very characteristic and typical appearance of reticulation and early fibrosis in silicosis. When sarcoid does fibrosis and architectural distortion, by and large, it tends to start out in the midzones with where the bronchovascular bundles start to curve. They create these C shapes, which you don't get in normal linear branching of undisturbed lung parenchyma. But in silicosis, this center of the apices, fibrosis with reticulation, is very typical and something to note and something to file away. Now, we can't leave the perilymphatic disease distribution without talking about lymphangitis carcinomatosis. Here is a patient with a cavitating cancer in the right apex, and on the lung windows, the lungs are filled with micronodularity. It's a high perfusion, and straight away we appreciate just how studded and beaded and irregular and nodular that oblique fissure is in the left lung. Just watch that as we come down. This is high perfusion nodularity, yes, the pleura is involved, and just wait till I show you the sagittals in this case, which show it even more impressively, this oblique fissure with this irregular, studded, beaded appearance, nodule, 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 and in the background, this lacy network of the interlobular septa, which are demarcated by this beaded nodular thickening. So, interlobular septal thickening, commonly overcalled as lymphangitis carcinomatosis in the setting of lung cancer, because the concepts are closely related, and once we see that thickening, we want to talk about lymphangitis. But the most common cause for interlobular septal thickening in the setting of lung malignancy is bulky, hilar disease that causes extrinsic compression of pulmonary veins and a segmental venous congestion. With this beaded appearance, the diagnosis is unequivocal. This is clear, classic lymphangitis carcinomatosis. So, in perilymphatic diffuse nodular disease, we're thinking about sarcoidosis, we're thinking about silicosis, we're thinking about lymphangitis. So, that's the framework. We're doing well. Now I want to add another layer across these groups. Are you ready? Here is a patient with high extent centrilobular ground glass nodularity. This high perfusion, innumerable faint ground glass nodules. Is the pleura involved? No. We've got a beautiful, thick black line around the periphery of the lung, sparing that immediate subpleural lung. We've got demarcation of the fissures. This is centrilobular distribution. They also have a few more confluent nodules scattered between. This patient is 35 years old. They've got no history of exposures. They've got significant respiratory impairment, and they've got this main pulmonary artery. This is grossly enlarged, remembering that the upper limit of normal rule of thumb for the main pulmonary artery is 30 millimeters. It's 27 in women, 29 in men. I would accept higher, let's say 33 in elderly people with no risk factors. But this patient has documented respiratory decline and acute pulmonary hypertension. And what they have is excipient lung disease. This is somebody with a history of intravenous drug use and injection of crushed oral medication. And excipient lung disease is a result of the embolization of insoluble binders that are present within these medications. And when they embolize throughout the lungs, we get a mechanical and inflammatory occlusion of the pulmonary vascular bed. This results in acute, often profound pulmonary hypertension, and in some cases chronic pulmonary hypertension. This is an important differential because the significant barriers to disclosing this drug use in patients may require the radiologist to be the first person to think through the possibilities. And it's a reminder that in the center of the secondary pulmonary lobule, there lives the terminal airway, but there also lives the terminal branches of the pulmonary artery. So see centrilobular nodules and look at the mediastinum, look at the size of the main pulmonary artery, and think about how the patient is presenting. Here is another patient, also in her 30s, grossly enlarged main pulmonary artery and chronic pulmonary hypertension. And in the lungs, she has this appearance. Is the pleura involved? No, she's got widespread, patchy, ill-defined ground glass nodularity, not the punctate fine nodularity that we've seen in other cases in the excipient lung disease and in the hypersensitivity pneumonitis, but this more thumbprints of ground glass. This is the typical radiological appearance of pulmonary capillary hemangiomatosis. PCH is a proliferative disorder. It may in fact be a low-grade neoplastic process. Histopathologically, there are diffuse angiomatous lesions, which themselves are proliferating capillaries. And it's a disorder that exists often alongside pulmonary veno-occlusive disease, PVOD, which is a patchy fibrous occlusion of pulmonary veins. They may in fact be along the spectrum of the same disease. And this patient went on to lung transplant. The explant showed both PCH and PVOD. This is the typical appearance radiologically of pulmonary capillary hemangiomatosis. Again, think about the pulmonary artery, look at the mediastinum, look at the size of the pulmonary artery in patients presenting with either acute or chronic disease. PCH and PVOD are important entities to appreciate because the classic first-line medical management for patients with idiopathic pulmonary hypertension results in a precipitous decline in these patients because of the different physiology that's driving the pulmonary hypertension. I want to go back to thinking about the pulmonary lymphatics, and I want to think through the bronchovascular lymphatic bed heading upstream out from the mediastinum and back to where the lymph begins to drain from the lung parenchyma, and appreciate for a moment that where the lymphatic bed joins the bronchovascular bundle is, of course, the center of the secondary pulmonary lobule. So let's pause for a minute and reflect that centrilobular nodules are an anatomical subset of perilymphatic nodularity. So that means that when we have patients like this, stonemason, upper zone architectural distortion, confluent opacities, progressive massive fibrosis, which is in fact the end stage of the perilobular reticulation that we saw in the other case. When we assess the nodular component of this patient's disease, and we see that it has a centrilobular distribution, that's not a problem at all. Are we worried about that? No, because centrilobular nodules are an anatomical subset of the perilymphatic nodule distribution. So respirable crystalline silica is inhaled in occupationally exposed workers and reaches and penetrates the lung parenchyma. So of course, there is a second driver of why this disease should manifest as centrilobular, but also the rest of this process involves engulfment of silica particles by pulmonary macrophages, which is a terminal event for the macrophage, which may then be engulfed by another macrophage and continue the cycle. And silica then aggregates in silicotic nodules, which undergo attempted lymphatic clearance. So that is the explanation why we have a peribronchovascular and a septal pleural distribution of nodularity in these patients, and why, as you see even on these lung windows, we will have mediastinal and hilar nodal involvement, seen in this case as coarse calcification. So, an explanation behind the manifestation of centrilobular nodules in silicosis. This is another patient with silicosis, 35 years old, a stonemason, and they have a profusion of scattered nodules. Is the pleura involved? No. This is a centrilobular pattern. Some soft tissue density nodules, but a large contribution of ground glass density nodules, and a widespread coronal distribution with some sparing at the bases. So how do we know that this is silicosis, and do we need to think about hypersensitivity pneumonitis? A clue in this case is that coarse calcification of the mediastinal and hilar lymph nodes, so a reminder to check the mediastinum for not just the pulmonary artery and the size of it, but the status of the nodes to flag whether or not we might be dealing with a lymphatic compartment disease. This patient has so-called accelerated silicosis, and the appearance of accelerated silicosis is centrilobular nodularity with a significant ground glass component. simple nodular chronic silicosis that we're familiar from days of yore is associated with occupational exposures in excess of 10 years. There's a really long latency period. Accelerated silicosis happens much faster, has a much more aggressive course, can come on in as little as 4 years after commencement of exposure, and is associated with working with artificial stone, engineered stone. Engineered stone is a much more toxic compound. So thinking about natural stone, thinking about marble, has a respirable crystalline silica content of 3%. Something like granite is up at 30%. But when you take the toxic silica compound out of natural stone and you concentrate it together and you bind it with resin and you put it in your kitchen, you have a respirable crystalline silica content of greater than 90%. This is a public health crisis that is much further reaching than asbestos. It occurs in younger patients. It has a much higher penetrance, with up to 1 in 4 occupationally exposed workers diagnosable with silicosis, and a course that can involve lung function decline, death, requirement for lung transplant, and really requires a public health response. Over the last 6 months, Australia has banned the production, use, and trade in engineered stone in multiple jurisdictions, and I'm looking forward to seeing that extending more broadly nationally and internationally. Accelerated silicosis with centrilobular ground glass nodularity. One more case of a patient with centrilobular ground glass nodules, and again, a patient with accelerated silicosis, young, short duration of exposure, and on this slice here, not a lot to differentiate from hypersensitivity pneumonitis, but when you get right up to the center of the apices, just like we saw in that first case of silicosis, we start to see that perilobular reticulation, which is the clue that this is what we're dealing with. Check the apices, check for that central apical perilobular distribution reticulation, because when hypersensitivity pneumonitis starts to fibrose, then we're talking about that 3-density appearance. We're talking about quite diffuse distribution of reticulation and fibrosis that is much more widespread in its distribution throughout the lung, whereas accelerated silicosis gives itself away with this central apical distribution perilobular fibrosis. Notice also the enlarged lymph nodes even on these lung windows with central fatty lucency, but large short axis diameter, and another clue that we're dealing with a lymphatic compartment disease. So, in the centrilobular pattern, the pleura is spared. Infection is 1st, 2nd, 3rd, and 17th on your differential diagnosis. We've got inflammatory etiologies of hypersensitivity pneumonitis, non-fibrotic, the new terminology. Respiratory bronchiolitis, low perfusion, seen in active smokers. We've got vascular causes, arterial causes. Check the mediastinum, check the size of the main pulmonary artery, think about excipient lung disease, think about pulmonary capillary hemangiomatosis, and we've got lymphatic compartment disease manifesting as pure centrilobular nodularity in the case of accelerated silicosis with ground glass opacity nodules. In uniform disease distribution, the pleura is sometimes involved. We've got miliary infection, miliary metastases, a common pattern that people are comfortable with. We've got perilymphatic disease distribution with centrilobular nodules, peribronchovascular nodules, septopleural disease, almost not a word. We've got sarcoidosis, we've got silicosis, and we've got lymphangitis carcinomatosis, not to be overcalled in the setting of smooth interlobular septal thickening, but looking for that beaded thickening with nodules studding the fissures and the interlobular septa. So we've got 3 disease patterns, we've got 3 distinct sets of etiologies, and we've got 3 interrelated anatomical explanations for the radiological manifestations. Thank you very much for your time.
What a fantastic way to start our new season of Friday live streams. And now we all know what to expect from Miranda, and that's just pure gold. If you enjoyed that, you won't want to miss Miranda again at Radiopedia 2025, where she will be presenting a case set on lung nodule CT, as well as co-hosting a chest imaging workshop with Sally Ayesa. So that's all we have for now. Don't forget to check out the conference registration page, and really importantly, don't forget to get your abstracts in for the hour posters. We really want as many of you to be involved in the conference as possible. I'll see you again for another Friday live stream. Bye for now.